This is your lecture on schizophrenia. I've divided schizophrenia into three lectures. So there's going to be this first one, which is going to be all the information about schizophrenia, the second one, which is going to be the nursing process, and the final one, which is going to be medications. These are the key terms that your text recommends knowing. These are not the same terms that you need to turn in for your first unit test, so be mindful of that. These are the text learning objectives. We'll cover them all through the next three lectures or three Zoom lectures. These are the nursing concepts that the book pairs with our schizophrenia patients. So what is schizophrenia? Schizophrenia is more of a syndrome or a disease process. It has many variations and it has a lot of different symptoms, and not two clients are going to appear the same way. Your book aligns it with kind of like cancer, how two patients can have cancer, but they're not necessarily going to have the same symptoms associated with their cancer. Your book divides it into two categories of positive symptoms, also called hard symptoms, and then our negative symptoms or soft symptoms. And we're going to cover those in the next few slides. Now, DSM-5 says for somebody to be diagnosed with schizophrenia, they need to have continuous signs of disturbances persistent for at least 6 months. And in that 6 month period, at least one of the month needs to have symptoms that are two or more of the following. And those are delusions, hallucinations, disorganized speech. And then our grossly disorganized behaviors, our catatonic behaviors, and negative symptoms. Of those two or more, at least one of them has to be those positive symptoms of delusions, hallucinations, or disorganized speech. It also has to impact the client's level of functioning in one or more areas, and that could be how they function at work, how their interpersonal relationships are being functioned, or their self-care. And the final thing is it has to not be related to any drugs or another medical condition. So when these clients first present, there's an extensive workup done to make sure that we're not having delusions and hallucinations because some other chemical disorder or brain tumor or something that could be affecting us. I also want to note that other textbooks talk about cognitive symptoms. Clients with schizophrenia a lot of times have problems with their memories, problems with problem solving, and then other texts also note in mood symptoms where they actually pull out some of those negative symptoms like a flat affect and they put that into a different bucket category. Your text just talks about positive and negative, so that's what we're going to talk about. So our positive symptoms. Text does a great job defining each of these and giving you examples. I'm going to cover a few of them. So we're going to talk about bizarre behavior. Bizarre behaviors are going to be these outlandish appearances. Their clothing might be just outlandish as well. They might have seemingly purposeless movements. They might have these unusual social or sexual behaviors. Delusions are going to be false fixed beliefs that have no basis in reality. And no matter what their delusion is, even if you can completely line up, they're still going to believe in that delusion. It is a false fixed belief. You will not be able to unfix it. Our hallucinations are false sensory perceptions. And you can have a false sensory perception in any one of your senses. So they might report tasting things that aren't there, smelling things that aren't there. Commonly, we'll have auditory hallucinations, and auditory hallucinations sometimes go even further into command hallucinations, where there's voices inside of their head that are telling them to do things. For whatever reason, these auditory hallucinations are not usually ever nice. They're not saying you're the best. They're usually saying you're horrible. Now those are just some of the positive symptoms. Now, some of the negative symptoms. Negative symptoms take away from the client, they take away from normal behaviors. So, like anhedonia is feeling no joy or pleasure from life or any activities or relationships they used to like. Apathy, feeling indifference towards people. Blunted affect is going to be a restricted range of emotional feelings, tones, moods. Flat affect is going to be an absence of facial expression. All right. So, schizophrenia. As I said, the DSM-5 criteria has very specific things that need to be met for somebody to be considered schizophrenic. Is usually diagnosed in late adolescence and early adulthood. Rarely does it manifest in childhood before the age of 5. Peak incidence is about 15 to 25 for men, 25 to 35 for women. It's estimated that 1% of the world population is affected. And that translates into nearly 3 million people in America who are, have been, or will be affected by the disease. Your book at this point in time also talks about schizoaffective disorder. Schizoaffective disorder is a mixture of those psychotic or positive symptoms and mood symptoms. So the signs and symptoms include those of schizophrenia and mood disorders, such as depression or bipolar. The symptoms may occur simultaneously, or they may alternate between the psychotic behaviors and the mood disorders. Some studies report that the long term outcomes for those with bipolar type schizoaffective disorder are similar to those with bipolar disorder, whereas those with depressive type schizophrenia are more similar to those with schizophrenia. Typically, treatment for schizoaffective disorder targets both the psychotic and the mood symptoms. Typically, they're going to use atypical psychotics as the first choice treatment, and mood stabilizers or antidepressants can be added on. Schizophrenia is going to be either very abrupt or it's going to be insidious, meaning it's going to be slow, gradual development of symptoms. Most often, it starts with social withdrawal, unusual behaviors, loss of interest or school at work, neglect and hygiene. And when you think about the age category that this hits, if you're somebody that's away at college, you're around a whole bunch of new people, they might not necessarily notice you. They might not notice the social withdrawal or, the neglect and hygiene because they might think that you've always been this socially withdrawn or, um, you know, non-hygienic person. So usually those early symptoms can go unnoticed. And it's not until they have the more positive symptoms of the psychosis where we're now having hallucinations, delusions, really bizarre behaviors that people then get diagnosed by it. Those who experience a gradual onset of the disease, which is about 50%, tend to have poorer outcomes. Um, in the long-term course than those who experience an acute or sudden onset. We're going to talk about that more here. So, when we have our immediate, it usually goes into two patterns. The one pattern is the client experiences ongoing psychosis and never fully recovers. Symptoms may shift in severity over time. And the other pattern, the client experiences episodes of psychotic symptoms that alternate with episodes of relatively or completely recovered from their psychosis. The more effective the client's response and adherence to their medication regimen, the better the outcome. The longer the periods of untreated psychosis, the poorer the long term outcomes. So, early detection and aggressive treatment for our first psychotic episode is really essential to promoting improved outcomes, such as lower relapse rates, higher improved insight, quality of life, and improved social functioning. These are some related psychotic disorders. So, schizoaffective, we talked about. Catatonia is categorized by marked psychomotor disturbances of either excessive motor activity or the client virtually appears immobile and motionless. We can have delusional disorders. This is when a client has one or more non-bizarre delusions. We can have brief psychotic disorder, and this is when the client's going to have a sudden onset of at least one psychotic symptom, such as delusions, hallucinations, disorganized speech, bizarre behavior, and it lasts from 1 day to 1 month. We can have shared psychotic disorders when two people have this similar delusion, and we can have schizotypal personality disorder, which we'll talk about that more when you get into personality disorders. The etiology of schizophrenia. So there is a lot of biological theories. We have our genetic theory, which focuses on parents, siblings, offsprings, and the percentage and chance that somebody's going to develop it. So if we have twins and they're identical twins, there's a 50% risk that if one twin has it, the other one is going to develop it. If they're fraternal twins, it's a 15% risk. When we look at our neuroanatomy and our neurochemical factors, we know by our recent scannings, like our MRIs, we can kind of see how the brain reacts, and we can see the dopamine reaction. And we know that, depending on where it is in the brain and the levels of the dopamine, we might have positive symptoms. If we have low levels of dopamine in certain areas, we're going to have our negative symptoms and our cognitive symptoms. So as we're, working with our medications, we have drugs that are going to change the dopamine receptors, and we're going to get on to all of that when we get into our medication stuff. The immunovirological factors, these are recent theories that have shown clients who are exposed to a virus can have alterations in their brain physiology, um, leading to schizophrenia. Same thing, women who are infected while pregnant, those babies also have an increased risk of having schizophrenia. Um, and that is kind of tied with that during crowded areas, colder weathers, and conditions where we have a lot of respiratory ailments, then we track that those children born during those times have an increased risk of schizophrenia. Our true or false question. Positive symptoms of schizophrenia include a flat affect and social withdrawal. This is false. Flat affect and social withdrawal are negative symptoms of schizophrenia. Cultural considerations, super important for a few different reasons. Number one, we need to remember that not all not all cultures have the same beliefs, and what might be a delusion to one, like witchcraft, might be accepted by another. Same thing if somebody says that they see the Virgin Mary or they hear God's voice. It could be a completely acceptable part of a religious experience in some cultures. So it's really important that we know that. Ethnicity has also been studied, and it's a factor in how clients respond to a lot of the psychotropic medications. So you need to be aware of that. Um, it just, some people have different enzymes that metabolize the medication differently. There's 6 of these enzymes that metabolize 90% of all medications, and we're not going to get into that because that will get us in the weeds. So, this is moving on to treatment. So we're going to end this lecture here, and then I will pick up treatment in the next, well, one of the next lectures.